Hello everyone, this is my first recording video, so try not to be so hard on me, I will appreciate it. The content provided in this video is for educational purposes only. I will be talking about dementias, okay? Dementias are becoming an increasingly significant socioeconomic and public health concern. As life expectancy continues to rise and expecting older adults will represent a historically large proportion of the population by 2050, I believe doctors, we need to raise awareness and stay up to date. So that's why I brought this topic to you. Dementia, also known as major cognitive disorder. Actually, the recent term is major cognitive disorder, but I believe everybody uses dementia. So you may read in recent literature major cognitive disorder, and they pretty much mean the same. It's important to mention, before we move on to talk specifically about dementia, that dementia and aging are not, so dementia is not something that we expect in aging, okay? What we expect is a mild cognitive decline, okay? But dementia is a diagnosis. Dementia is a disorder that needs to be treated, needs to be diagnosed. Okay, those are the big differences with a mild cognitive decline and dementia. Okay, so we don't expect just because you are 80 years old that you're gonna have dementia. Okay. So now we can move to the criteria. We have two different criteria that are pretty much the same in the sense of we need to have a decline from a previous normal level. Okay, so 6 months ago I was able to drive, now I can't drive. Or I was able to manage the money in my family. Now I'm not able to do it, right? So I was able to do it before, now I can't. And we have to rule out other conditions, organic and mental disorders, that can mimic or can't have some behavior and or cognitive symptoms, but don't fit or should not fit with dementia. The patient should not be diagnosed with dementia if we are suspecting schizophrenia, for example, right? So it's important to keep these things in mind. Okay, so regarding the DSM-5, they establish 4 criteria. As I mentioned, a significant cognitive decline. Second, these cognitive deficits are interfering with independence in everyday activities. The third, the cognitive deficits do not occur exclusively in the context of delirium. As we know, delirium is a very common condition in the hospital, right? So we need to make sure that this is not delirium. And because we know delirium is reversible, so the patient will come back to the normal status, which won't be happening if they have dementia, for example. The fourth is the cognitive deficits are not better explained by another mental disorder, as I mentioned, schizophrenia or major depressive disorder. Now, the other criteria encompass 5 points with some subtypes. So, first of all, as the other criteria, it has to interfere with the ability to function. Okay. Second, you have a decline from a previous level of functioning. Third, these symptoms are not better explained by delirium or other mental health condition. Fourth, cognitive impairment is detected and diagnosed through a combination of history and objective cognitive assessment, for example, MOCA, and the neuropsychological testing should be performed when the routine history and bedside mental status examination cannot provide a confident diagnosis. Okay. Now the fifth point. The cognitive or behavioral impairment involves a minimum of 2 of the following domains. So we need at least 2. First of all, or the first subtype, impaired ability to acquire and remember new information. Or forgetting events or appointments. You told me your name, but now I don't remember it when I used to remember. Second, impaired reasoning and handling of complex tasks. Poor judgment. For example, I'm unable to manage finances. My ability of decision making is poor. The third, the C, is impaired visuospatial abilities. I'm unable to recognize faces or common objects. D, impaired language functions, speaking, reading, and writing. I have difficulty spelling. I have difficulty finding words. Okay. And the E, changes in personality, behavior, or temperament. Symptoms include mood fluctuations, such as agitation, impaired motivation, apathy, loss of drive, and so on. So we need at least 2 of these to be able to make a diagnosis of dementia. Now, in medicine, we subdivide the term dementia into 2 groups. One is the reversible causes of dementia, and the other one is irreversible causes of dementia. And this means reversible, as the term implies. It's gonna be the patient. It's gonna be able to come back to their normal status. And the conditions that can cause dementia or reversible dementia are as follows: neoplasms, metabolic disorders, hyperthyroidism, renal failure, hepatic failure, Wilson's disease. Trauma, such as subdural hematoma, can cause a reversible cause of dementia. Toxins, alcohol, infections, autoimmune disorders, drugs, anticholinergics, and sedatives. Nutritional deficiencies, such as thiamine, folate, vitamin B12, and vitamin B6. Psychiatric disorders such as depression, schizophrenia, and mania. Other conditions, normal pressure hydrocephalus, and sarcoidosis. So these are the causes that can give you dementia, but if you treat it, in most of the cases, well, not in most, but in some of the cases, you will go back to your normal status, or at some degree, some reversible or cognitive status. Now, irreversible causes of dementia. These ones are the dementias that we call degenerative diseases, because they're gonna get worse with time, and there is not a coming back from it. Okay, the most common one is, as we know, Alzheimer's disease. This is the most common type of dementia. The second most common is, depending what is the classification that you are using, but it can be vascular dementia. Although Parkinson's disease is the second most common degenerative disease after Alzheimer's disease, and also they present with dementia. Okay, so we have different types of dementia. It can be properly or part of the types of dementia, like Alzheimer's disease, frontotemporal dementia, we have Lewy body dementia, we have vascular dementia, and we have other types. For example, Parkinson's disease, we know that is a disease that involves tremors, rigidity, and dyskinesia. But they also they also present dementia. Okay, so infectious diseases such as leukoencephalopathies can present or can cause an irreversible dementia. This is important to acknowledge. Now, what do we use to diagnose the patients? We use three things. Well, actually just two. We use clinical diagnosis. So we can take the history from the patient and the family member, the closest family member, or a close friend. Why? Because we need to know what are the changes in cognitive functioning and behavior wise. So we may have to ask someone else besides the patient. Then neuroimaging and other tests. So neuroimaging will be one of our best studies to do besides the neuropsychological testing, such as MOCA, because this one can help us to differentiate other causes. Okay. Pathological diagnosis, we don't do it. We know that the confirmative diagnosis is pathological, but of course we don't do it. Okay, we don't do it because it's very invasive, and with the clinical and other studies, cognitive tests and neuroimaging, we are able to have an accurate diagnosis and be able to treat the patient. Also, with the new neuroimaging that we are having, the PET and other imaging, we are having even an increase of the accuracy with our diagnosis and regarding these patients. So the clinical, as I mentioned, we can take it from the patient and or the family member, right? What we need to know is the full past medical history. What are the previous conditions, right? Small vessel disease, of course, we know in people if they have diabetes, if they have hypertension. What is the timeline when the changes started? Or it started a year ago, or it started 6 months ago, and it's becoming so bad. Okay, is there urinary incontinence? Is there history of trauma, head trauma, other deficits that we may need to ask, right? Any weakness, any alterations in sensory? What are the other things that can help us diagnose this case, or help us in looking for the need of imaging? For example, if the patient has weakness, I may have or rush into a MRI or CT, right? So depending on the history, we can direct our next studies and do the workup for the patient, do a focus workup for the patient. Of course, it's very important to do a neurological exam plus physical exam, because we know that are reversible causes of dementia. And it's pretty important to rule out mostly three things in patients that we are suspecting dementia: thyroid, depression, and vitamin B12 deficiency. So we can do an assessment with the physical exam, history, and see if needed to do a thyroid exam and so on. Actually, most of the centers will do that even if they have a normal physical exam, because they're often missed. As I mentioned, the standardized tests, MMI or MOCA, are really ideal for the patient to have an idea of the cognitive status of the patient, right? And this also helps us to, when we are following the patient, for example, like 6 months or a year, to see what are the changes that we are seeing, right? So it's important to have a baseline for these patients. So neuroimaging, actually, we do it for all patients, sooner or later, okay? We can do a CT or MRI if we are in an ideal center. We can order an MRI, right? We know that this for vascular and all the sensibility of MRI, we prefer that one, but CT can be good to rule out, for example, a subdural hematoma or so on. As I mentioned, TSH, vitamin B12, and CBC can be ordered as a screening test to rule out reversible causes of dementia. Also, we should do Hamilton and Beck tests to diagnose or to rule out diagnosis of depression and anxiety. And I have to mention that actually the patients are often they often have depression, anxiety plus dementia. So this is not weird to find, right? But this depression or anxiety may worsen the dementia itself. So we need to make sure that, or we need to assess that in order to give comprehensive management for the patients. Sometimes it's just the depression that is affecting the cognitive and behavior domains, but sometimes we can have both, right? Sorry, this is okay. This is an MRI. This is a T1. We see a coronal cut or coronal view. This is the first image on the left. We see a normal MRI. We see the structure. We see a very nice gray and white matter. There is not any abnormalities. On the middle or second picture from the left to the right, we see that the gyri sulcide are getting increased. So we have more space. That's what we call atrophy, okay? That space is mostly on the temporal lobe in that image, okay? It's very noticeable. And the third picture, I will say, this is we see atrophy, but not as bad as the picture in the middle. Okay, there is some atrophy on the last picture, which again we don't base our treatment or diagnosis on the severity of atrophy, right? We base mostly on the clinical. What are the deficits that the patient is having, and if they match the imaging that we are having here, right? Or what are the other conditions that we may see on the MRI that can be causing dementia. For example, hydrocephalus, normal pressure hydrocephalus, or we can have some small vessel involvement, which is not the case in these images, but just to keep it in mind, right? That we are trying to rule out or rule in causes that are common causes for dementia. Now the treatment depends on what is the cause, right? If it is normal pressure hydrocephalus, we have treatment for that, right? We can do a ventricular shunt. If it is depression, it's a reversible cause of dementia, we treat the depression, right? If even after treating the depression, the patient is not getting better, well, we may suspect that something else is happening, right? But we mostly do, well, this is for reversible causes, of course. We treat what is underlying, right? If it's due to hypothyroidism, we give levothyroxine, sorry. But in the case of irreversible causes of dementia, we have a few medications that we use. They don't change the outcome. They don't change the progression of the disease. That's what I wanted to say. But they can show some benefit to the patients, okay? We have medications such as donepezil, rivastigmine, galantamine, and memantine, okay? Those gonna help us. This is for the treatment of Alzheimer's, okay? For vascular dementia, we still use kind of the same medications for them. We use either donepezil or memantine, but mostly this is for Alzheimer's treatment, okay? For vascular dementias, we aim to prevent more vascular damage, right? Controlling the blood pressure, if anticoagulation is needed, or any other further management for the case. But if we want to help with the memory, a little bit with the memory, we can give memantine. And that's it, okay? For mild to severe Alzheimer's, we use donepezil, as well as rivastigmine. For moderate to severe, we use memantine, okay? There are some medications that we use that are off-label. We use it because there is not much that we can do for patients with some types of dementias. That if the mechanism of the drug seem to make sense, and in the sense of this may help the patient, we can give it. We have given, and it showed like it's safe. But I just wanted to mention that yes, it can. There are some medications that we can give to with the patients with other type of dementias. For example, Lewy dementia, etc. But they are off-label. They are not really used as these medications for Alzheimer. And the prognosis. Now the prognosis. So for Alzheimer's, we have 3 stages. We have the mild Alzheimer's, moderate Alzheimer's, and severe Alzheimer's. In total is 8 to 12 years, okay, post-diagnosis. The large length of time, it's gonna be the moderate Alzheimer's, which it's between 5 to 8 years. For Parkinson's disease, the life expectancy is around 7 to 10 years, And in the late stage of Parkinson's is when people start complaining or start being affected by dementia. So this is a little bit of the prognosis of the two common pathologies. For frontotemporal dementia, the life expectancy is 7 to 10 years post-diagnosis. So here we have a case. So let's review it together. So this is a 64-year-old woman is brought to the physician by her son due to cognitive impairment. The problems started 3 months ago when the patient stopped cooking and cleaning the house. Her gait has become unsteady and she has had 2 near falls over the last 2 months. The patient still enjoys being around the family and playing with her grandchildren, but seems mildly forgetful. She has a history of hypertension, a stable coronary artery disease, and diet-controlled diabetes mellitus. The patient's blood pressure is 155 over 62 millimeters of mercury, and pulse is 89 per minute. Physical examination shows a pleasant woman in no distress. There is mild muscle weakness on the left side and prominent pronator drift of the left arm. There is non-muscle rigidity. She is unsteady in the lumbar position with her eyes closed. Which of the following is most likely cause of this patient's cognitive impairment? So let's review it. First, the problems started 3 months ago. This is rapidly progressive dementia, I would say, 3 months, okay? Usually for Alzheimer, they're gonna come to you with the symptoms starting a year ago. So this is kind of recent, okay? And then they said the case tells you that she has been unsteady, nearly 2 falls, and doesn't have any behavior changes so far. She has vascular risk factors. She has coronary artery disease, diabetes mellitus, and hypertension. The blood pressure is high. It's mostly the systolic, and there is mild muscle weakness on the left side and prominent pronator drift on the left arm. Pronator drift is telling you about upper motor neuron. So this is most likely to be vascular dementia. Okay, 3 months ago, probably she had a small vessel occlusion 3 months ago, and she has vascular risk factors. She has high blood pressure. She has pronator drift on the left with muscle weakness. So this is most likely to be a vascular case, a vascular type of dementia. Thank you for watching this video, and I hope you liked it.